This morning we have Dr. James Yu giving us a talk on advances in prostate cancer radiotherapy. Dr. Yu is an associate professor of therapeutic radiology and the director of Yale Medicine's prostate and genitourinary cancer radiotherapy program. As a member of the Cancer Outcomes Public Policy and Effectiveness Research Center at Yale, Dr. Yu's research centers on the comparative effectiveness of new radiation technologies. He is currently a senior editor of the Journal of Practical Radiation Oncology and is on the editorial boards of several journals, including the Journal of Clinical Oncology, Journal of Clinical Oncology, Clinical Cancer Informatics, JNCI, and European Urology Oncology. This summer, he will co-chair the ASTRO/RSNA research workshop on oligometastatic disease in Washington, D.C. So welcome, both of you.
Thank you, Dr. Zhang. Thank you very much. I'm delighted to be here. Thank you all for inviting me. A lot of this, I think, you will know more about, being urologists who treat prostate cancer, particularly, I think, some of the discussion about the impact of new genetic tests on prostate cancer decision-making. But oh, there we go. These are my disclosures before we get going. I'm a consultant with Augmentics and Boston Scientific, and I'm going to talk about SpaceOAR during this talk. So this is very relevant, this conflict of interest. Unlike other conflicts of interest, this is a very relevant one. So because of that, during the talk, when I talk about SpaceOAR, there'll be a visual cue to take everything that I say with a grain of salt. That's the visual cue. That's I don't know if you guys remember from Simpsons, this is the guy who sold the monorail to Springfield. So please be aware of my conflict. I think I'm getting the hang of this. So I'm going to talk about 5 different things during this talk. I'm going to talk about moderate hypofractionation, which after I explain, probably most of you are going to go, that's it? That's the big, it's very similar to the radiation that we were giving before, and that's true. But I'll also talk about radiosurgery, which is something we've been doing here at Yale for a couple of years now. Rectal spacing, I'll talk briefly about again. Take it with a big grain of salt. I'm going to talk about incorporating genomic tools for clinical decision-making in the radiation oncology space. And then I'm going to talk about some updates for 2018, studies that came out that I thought were particularly relevant and practice-changing potentially for radiation oncologists. And then finally, I'm going to talk about a subject that comes up more and more in tumor boards, the treatment of oligometastatic disease. Right? These are patients that we used to say hormonal, there's a metastasis, it's time for hormonal therapy. There's nothing more we can do. But that type of thinking is rapidly changing. And honestly, I think is one of the more exciting areas of investigation in the treatment of prostate cancer. All right. So here's some historical context. I was last invited to give this talk in 2010, and that's right. That's right. Every 10 years, I'm like a cicada, right? Something like that. So everyone, I was here in 2010 and I gave grand rounds, and I look back at the slides. Everyone was getting 75.6 gray, in 42 fractions, right? Everybody, you know. So you sent them to me or Dr. Peschel. Everyone got 8 weeks of daily radiation, and we were still treating low-risk disease. There was still the Gleason 6 patient coming who wanted treatment. We said, yeah, you know, it could be helpful for you. We're still using what's called 4-field pelvic radiation, which was very large field pelvic radiation. This is very different from what we do now. And so, you know, I still follow these patients. I'm sure all of you do too. These are the patients that have the major rectal toxicity after, you know, radiation for their high-risk prostate cancer. We were rarely doing adjuvant radiotherapy. I don't know, 9 years ago, if someone came with a rising PSA after surgery, we would tell them there's no evidence that, you know, any sort of radiotherapy really helps. Nowadays, obviously, that's changed greatly with the 3 randomized studies, with the Thompson SWOG study. And we were still quite suspicious of radiosurgery here at Yale. And this whole concept of moderate hypofractionation wasn't even on the radar. So So things have changed greatly. And at that time, much of the research was still kind of figuring out whether IMRT, this kind of newfangled form of radiation, was better than the older kind. And now, obviously, we've moved on from that. And we were still trying to figure out what to do with image guidance, meaning, we used to actually, when we lined patients up for daily radiation, we would have 3 marks on their body and line them up based on the laser marks. If they were off, we'd kind of pull on their skin. I mean, these are, men in their 60s and 70s. We'd kind of pull on their skin until those marks were aligned, not shifting their internal anatomy at all. So things have changed in the last 9 years in terms of how we deliver radiotherapy and how we verify that treatment is actually going to where we want it to go. So the first part of 5, and if I start to get behind, look forward, and I'll start talking more quickly. Moderate hypofractionation. So standard therapy is daily treatment, Monday through Friday. Each treatment delivers about 1.8 to 2 gray per day, gray being the unit of radiation dose. And this kind of fractionation was arrived on after decades of experience, trying to figure out what was the most efficacious treatment with the least toxicity if you treat a huge area. And that was about 1.8 to 2 gray per day. And then we figured out, well, you need to give about 40 of these treatments to prostates in order to do some sort of benefit. People started to think, well, that's actually a very long and arduous treatment for a patient, and it actually costs a ton of money for the US healthcare system. Can we do this shorter? And so people came up with something called moderate hypofractionation, which is 2.4 to 4 gray a day. And you shorten the treatments down to anywhere from 20 to 30. And then some very enterprising folks thought, well, what if we just give 5 treatments or 1 treatment? And this is the radiosurgery paradigm. In Europe, people give 6, 7 treatments. Why do we give 5 in the US? Well, because that's what Medicare defines as radiosurgery. And if Medicare defines it that way and the insurance companies go that way, no one's going to do 6 treatments. Everyone's going to do 5 or fewer. So this moderate hypofractionation has taken off. In the UK, a couple years ago, it was about 20% of all patients. I would guess here in the US, it's probably somewhere from 10 to 15% of all patients undergoing radiotherapy. And it could reduce the number of fractions by about 200,000 in the UK. And in the US, theoretically, it could save the healthcare system millions and millions of dollars. If you're on the other side of that coin, it could take away thousands and thousands of dollars from your radiation oncology practice. So this is something that's very interesting to study from a health service standpoint, right? Do radiation oncologists adopt a technique that is better for the patient, better for society, but worse for their pocketbook? And how does that disseminate? And what are the barriers to that dissemination? For prostate cancer, it's about $9,000 less per cancer patient to you, the radiation oncologist, if you adopt moderate hypofractionation. Luckily, we're at Yale. We try and do the right thing, and we've adopted moderate hypofractionation quite readily. The interesting thing about radiosurgery is it's also cheaper than standard fractionation, which is interesting, right? This is a new technology, more technologically intensive, more to go into it, but it's cheaper than the older form, and that's because Medicare, as a fee-for-service, pays per treatment and per week of radiation oncology, so it adds up. So radiosurgery is actually cheaper than standard fractionated radiation. So if it's cheaper and more convenient, why doesn't everyone just do it? Well, because we're worried. There's a concept in radiation oncology of this thing called the alpha beta. And the alpha beta is basically what is the relationship between how much radiation you give each time and the likelihood of that outcome. So you can have an alpha beta for cancer control, and you can have an alpha beta for toxicity. And we didn't know what the alpha beta of toxicity was, particularly long-term toxicity. And so radiosurgery, a lot of us were very worried that these 3 years out from the radiosurgery, people are just going to start to fall apart because of these large doses we were giving at a time. fortunately, that's been largely mitigated. These moderate hypofraction studies, major studies, thousands of patients have shown good outcomes. And also, we see that the toxicity happens a little bit earlier during the radiation course, which makes sense, right? You're giving more each time. The course is shorter. Of course, the side effects are going to occur earlier. But what was key was that the long-term toxicity seems to be equivalent for moderate and standard fractionation. So arguably, moderate hypofractionation is, I would say, the standard of care for patients with intermediate risk disease. And that the folks in the UK agree with that, and I think most of us in the US are now coming around to that idea. You can do it in 20 treatments, like the folks like Dr. Dernelly and the folks who ran the CHIP study. In the US, we have our own study because we're America, right? We have a UK study. Our study looked at 28 treatments versus 34, I think. 39, sorry. We found no difference in overall control. And toxicity was also largely equivalent. There was a little bit more toxicity in terms of G1, grade 2 GI and GU rates, but it was not major. And so based on that, you can do, I tell the residents this all the time, because they ask subtle questions about radiation technique or radiotherapy for prostate cancer. The bottom line is prostate radiotherapy is like the Outback Steakhouse. There's no rules. But essentially, you can do 19 fractions, 20. You can do 28, like the RTOG. And if you're still hesitant and you still want to hold on to standard fractionation, you can say, look, there's no 8 or 10-year data. And toxicity can still occur 8, 9, 10 years out. So I'm going to hold on to that standard fractionation. So you can do 44 fractions, 45. You can do 39. So if you want to do radiosurgery, you could do 5. Some people are doing 2. So essentially, you can pick any number and almost justify it. However, moderate hypofractionation for us, the folks who refer patients to me may notice that no one's getting 9 weeks anymore, or very few patients are getting 9 weeks anymore. Now everyone's getting 5, 5.5, or they're getting a week and a half. So treatments are much shorter, and I think that's good for society and good for the patients as well. So then the question arises, which is better, radiosurgery or moderate hypofractionation, right? There haven't been any comparative studies comparing radiosurgery and moderate hypofractionation in terms of a randomized study. We know quality of life radiosurgery is actually quite good. These are EPIC scores, the Expanded Prostate Index Composite survey scores. So these are patient-reported outcomes. The higher the score, the worse. The higher, the y-axis here, the worse the quality of life. And you can notice that the radiosurgery arms do seem to be better, at least historically, compared to pooled outcomes of standard fractionation and brachytherapy patients. Now, take this one with a grain of salt. Many of the patients in the SBRT arm are from Georgetown. Georgetown's published many of their papers on their cohort, and they've done phenomenally well, but it's a very high volume center. And the folks at Georgetown are very good at what they do in terms of radiosurgery. Whether that translates globally, I think it may be true, and actually more and more data with larger and larger data sets are coming out saying radiosurgery is safe and effective. But I would take this study with a little bit of grain of salt. Again, PSA relapse-free survival seems to be good in a selected group of patients who've undergone radiosurgery. And our radiation therapy oncology group, RTOG, now part of NRG, ran a study comparing 2 radiosurgery fractionation schemes, 5 versus 12. I didn't think that that was even a relevant question, 5 versus 12. I think the more important part of this study is that patients did pretty well regardless, with very little acute toxicity. And so now we have a prospective study of radiosurgery done by a cooperative group showing that radiosurgery is safe. And so this kind of pushed me into adopting radiosurgery a little bit more, and more evidence was accumulating. So again, which is better, radiosurgery or moderate hypofractionation? Well, there were no comparative studies, so we did a pooled analysis, individual patient meta-analysis here. I called all the people I knew who had data sets, and we got most of them, and we compared moderate hypofractionation to radiosurgery. Again, the Georgetown data was in this. And we found that patients who had radiosurgery had fewer minimally detectable declines in their patient-reported quality of life compared to the folks who had moderate hypofractionation. So again, more signals that radiosurgery does seem to be quite good. And perhaps some of the fears that we had here at Yale 10 years ago can be alleviated to a large degree. Well, you know, a pooled individual patient meta-analysis is all well and good, but we need a randomized controlled trial. And so this has been mounted by the NRG. It was started about a year and a half ago. Accrual's going okay, but we're randomizing between 5 treatments and the American 28 treatments, moderate hypofractionation, and we'll see whether prostate radiosurgery is non-inferior with regards to biochemical control and better with regards to quality of life. And we should know this in a couple of years. So that's intact, moderate versus radiosurgery for the intact prostate, right? Primary treatment. What about, yeah?
I noticed those are all intermediate risk, low risk patients.
Right. Correct. Right. So the vast majority of patients who've gotten moderate and radiosurgery are intermediate or low risk patients. There's more patients who got moderate hypofractionation in high risk disease than for radiosurgery. So for high risk, we know we can incorporate hormone therapy. I didn't mention this, but some of those studies incorporated hormone therapy with the moderate hypofractionation. So as you kind of shade higher in risk, the more I go away from radiosurgery and lean more towards moderate hypofractionation because of the importance of hormone therapy in combination with radiation for high risk, for sure. There are some folks doing radiosurgery for high risk prostate cancer. I don't know if I agree with that because that tends to be, in my eyes, a little bit more of a regional disease than a localized disease. And there isn't any data incorporating hormone therapy and radiosurgery. And so if we have randomized studies that show a survival benefit to the addition of hormone therapy to radiation for high-risk disease, why completely shift course and just do radiosurgery alone? That didn't make sense to me. Certainly, I think for surgery as well, there are studies now being suggested or kind of in development looking at how do we treat these high-risk patients with local therapy, and how do we intensify? Do we intensify local therapy? Right, that's another question we have all the time in tumor board. You know, what's the utility of surgery in high-risk disease? The ultimate local therapy intensification. So obviously, we don't know.
And so these are PSA endpoints, right? So are these failures in field? Are they
Right?
I mean, it seems like it would make sense to, have some type of imaging correlate as well. Because that might be the big question, especially for high risk disease, where you wonder, are they failing distantly, and then that really can't be modified by local therapy.
Right.
Maybe it can.
Right. So I mean, PSA endpoint is the easiest endpoint, right? So when we design these trials, it's we pick the easiest, But there is a study. I think Matt Abramowitz at Miami is doing a moderate versus extreme, but their endpoint is 2-year biopsy. And so they'll go in and actually see whether there's a local recurrence or not. So it'll be interesting to see the results of that study relative to the results of 5, for sure. Yeah.
You showed a slide and you said the long-term complications are about equivalent, but they get high rates of shorter-term complications.
Right.
Higher upfront dose. As urologists, we see this all the time with
hemorrhagic cystitis, and that is many, many years.
Yeah. Yeah. Right. Yeah. No, the hemorrhagic cystitis. I feel like that's relatively underreported as well, at least in the radiation oncology literature. So you're right. These toxicities can occur many, many years after the radiation treatment, and that's always going to be an argument not to adopt something new in radiation oncology for sure. But I agree completely with you that you need to have at least 5-6 year data to at least feel comfortable about something. And then whether it's 8, 10, 12, I think there's arguments on both sides for sure. All right. So what about post-operative radiation, which actually for us now is, 9 years ago we were barely doing it. This is like half, and some places around the country it's more than half of their clinical volume doing post-operative radiation therapy. And we've kind of hit this weird place where post-operative radiation takes longer than intact radiation, right? I give 8 weeks of daily radiation for post-operative treatment, whereas for an intact prostate, I can give 5 in some cases. So a lot of folks are looking at, well, all right, let's shorten up the treatment in the post-operative space. This is more than half of our patients sometimes. What if we can give 25 treatments instead of 38? And so this was a study that was recently mounted by NRG and actually accrued so fast that it closed, I think, in about a year. So this is already closed, and hopefully we'll have results from this in a couple years. I put a couple patients on this study. They did beautifully in the short term, Dinesh, right? So who knows how they'll do in the long term, but there is some mirroring of acute toxicity and long-term toxicity. So I hope that in the future, in 10 years or so, I'll come back and tell you, hey, the standard of care now is 25 treatments. Or there's actually a couple studies out there looking at radiosurgery for post-operative disease. Now, I'm a little worried about that, right? Because this is an anastomosis, and you guys should be especially worried about this. What is the, how safe is it to treat a surgical anastomosis with very high doses of radiation where you're worried about fibrosis and devitalization and all of that stuff? So I don't know the answer to this one yet. I have a feeling 25 is going to be the standard. I really don't see us doing radiosurgery to post-operative bed, right? Because the other thing about this is we're treating an area of potential disease here, right? We're not treating a defined anatomical target. We're treating a kind of a cloud of where we think there may be microscopic disease. And that doesn't strike me as a radiosurgical problem. But again, this completed accrual last year, and we'll know in a couple years, hopefully, what the ideal fractionation is. In the meantime, this is what we do here. At least this is what I generally recommend. Obviously, there no rules, just do. But in general, I recommend observation for the low risk. If it's a favorable intermediate with a grade group 2, I do radiosurgery or moderate hypofractionation. If there's unfavorable intermediate, meaning there's a little more Gleason 4 in there, I'll recommend hormone therapy. And high risk, we start thinking about radiosurgery boost. And we have a quality of life protocol where we're following these patients. We have about 25 patients who've gone through this high risk protocol. All right, so here's everyone take this with a grain of salt. There's the guy from The Simpsons. So believe it or not, I mean, this may this may be a shock to you guys, but radiation can sometimes cause toxicity. So where does radiation toxicity occur when we treat prostate cancer? Obviously, the anterior rectal wall, bladder, and we can't avoid the urethra. We actually treat the urethra through and through when we radiate. So prostate rectum spacing has kind of come on strong in the last couple of years. We started doing it about, I don't know, a couple of years ago, maybe. It was FDA approved maybe a year ago. And what it is, it's the injection of a hydrogel into the space between the prostate and the rectum. And what it means for me as a radiation oncologist is that I no longer have to include the rectum in my target. So now this may come as a shock to some of you, but in typical prostate radiation, when you deliver radiation, you have to put an error margin on the prostate, and the rectum is literally in the planning target. So we're literally radiating the rectum on purpose for prostate radiotherapy before hydrogel, because there's a chance that the rectum would be, the prostate day to day would push back posteriorly into the rectum. And so we were literally including the rectum in our treatment planning target. We don't have to do that anymore with SpaceOAR. If the prostate is pushed away from the rectum, there's enough space there that we no longer have to include the rectum in our target. That changes everything in terms of the amount of radiation that the rectum gets. This is something that we look at called a dose volume histogram. But essentially the point of this is that prostate, when we do prostate radiation, the doses of the rectum are now approaching very, very low numbers. And in a randomized study, this meant that quality of life was much improved for patients who had the SpaceOAR versus those who got sham. In addition to that, here at Yale, we put in, or not we, but Mike and Preston put these in. These are Calypso Beacons. These are radio frequency beacons that can track the motion of the prostate in real time. And the cool thing about this is actually user independent for us. The therapists don't have to be the ones to turn the machine off. The machine will not deliver radiation if in a millisecond before the prostate has moved more than we want it to. And so this is what we see when I'm standing in there, and well, not in there, but in the control room watching the treatment. If the prostate moves beyond what I have preset as the limit of motion, the machine will stop. And you'll actually see the linear accelerated head stop in its arc. And then as the patient drifts back into tolerance, it'll continue on. So this is really great. And also, once we got this system, we realized how much the prostate has been moving this whole time, right? Like, people, the patients pass gas and the prostate moves like a centimeter. Or we can, sometimes we'll see the prostate go up and back down. We say, oh, there's a bubble of gas moving through. So I think real-time tracking of your prostate is important, particularly for radiosurgery. And it's been very eye-opening. This is what I see when I do a treatment plan. I merge the CT scan and the MRI. You get this nice pad of hydrogel that Michael and Preston have generously placed in between the prostate and the rectum. And then we contour out the Calypso Beacons. And then this is my, what's called PTV margin, my planning treatment margin. You can see now it no longer encompasses the rectum. This is very nice. So that's 2 parts out of 5. This is the part that some of you may be more interested in or have much more knowledge about. But this is also something that comes up all the time in tumor board, right? How do we incorporate Decipher, right? Prolaris, all these new decision-making tools into our decision-making. And this is something that we're struggling with a lot and trying to incorporate a lot in radiation oncology. There's a lot of tools out there. The one that we use the most, probably because most studies have been done in it, or it would be actually very interesting to look back at and see whether it's also because the company has invested more in radiation oncology. But for some reason, we're using Decipher or reading more about Decipher than other tests. It's an RNA expression-based genomic classifier. And then Decipher also provides kind of the whole set of genomic data. And so you can pull out different tests, not just the Decipher score. Prolaris is another test out there. Oncotype DX, and then also the androgen receptor V7 marker may predict for response to hormonal therapies. And then folks at Moffitt have worked on this thing called a radiation sensitivity index, or GENO, and then they adjust the radiation dose by this genetic index within patient. So there's been a lot of work done, and I think over the next couple of years, we'll start to use this to make decisions. Recently, this is a paper that I've gone back to many times. Dan Spratt at Michigan now pooled together thousands of patients and tried to come up with a schema for how do we incorporate the genomic data with the clinical. Okay, so what happens when you have a patient who has a Gleason 3+4, but then their decipher comes back high, right? That happens all the time, right? Well, so the suggested course of action by Dan is that you add those two up, you add a 1 plus a 2, and you come up with a 3, and you call it an unfavorable intermediate. And that to me means this patient with a Gleason 3+4 has now bought themselves 6 months of hormone therapy, right? This is a suggested course of action. We are, as we speak, developing clinical trials to investigate this. There's going to be, hopefully, if NCI agrees, there's going to be a study that will take high-risk patients and then stratify them by high or low-risk decipher and either escalate or de-escalate the length of hormonal therapy. And the same for intermediate risk. If you have an intermediate risk and you have a low decipher score, theoretically, so you'll be randomized to no hormones or hormones, and then we'll figure out whether that's the right thing or not. So in 10 years, I'll come back with the answer to this. But this is just a suggestion, and I've actually taken this and run with it. I think this makes a lot of sense to me in the absence of randomized data. I'll skip that. It actually hasn't really gotten anywhere. So someday we'll be able to use a genomic classifier to define treatment. What about adjuvant therapy? This is actually a lot more work has been done in the adjuvant setting because a lot of these genomic tests, you needed the prostate. So in the post-operative setting, Decipher does help. If there's a patient that we don't know whether we should give post-operative radiation or not, and they have a high Decipher score, that actually it has been shown to indicate a benefit from radiotherapy. Once again, a high Decipher score, their radiation does lead to a separation in the curves, whereas a lower Decipher score, they do equally as well if you do radiation or not. So I have been using on occasion Decipher. Portos is a kind of a subset of the Decipher grid. So again, you can consider this to be Decipher as well. But essentially, I think we're going to start using this more and more in tumor board for those folks who have a Decipher score, who are on the fence about whether they need adjuvant radiation or not. We'll push them a little bit more towards adjuvant treatment as opposed to kind of letting them be watched for a little bit. And then this is a study that's ongoing right now. This is Dan Spratt's study looking at looking at intensification of therapy in the salvage setting. The reason I put this up is because they're going to use this PAM50 score to stratify patients, pre-stratify patients in this study. So it's an interesting use of a genomic indicator. And the PAM50 score was actually taken from breast cancer, where they stratified patients into luminal A, luminal B, and basal subtypes. And they're doing this all over the place. I think they started to do this in bladder too. So it's very interesting. And it looks like prostate cancer also substratifies into luminal A, luminal B, and basal subtypes. So we'll see whether that's actually true once we're done with this study. Once they're done with this study. So summarizing this section again, it's reasonable, and I think we're starting to do this, right, in tumor board. We're starting to incorporate these genomic tools. We're kind of stumbling around, but we're starting to incorporate these genomic tools. And there's some evidence that Decipher can tell you which patients will benefit from adjuvant radiation versus not. In the meantime, steam on, let's say. All right, so we're on track. So in this section, I'm going to talk about updates from this year, studies that I thought were particularly important to talk about. So in Astro in October, the RTOG SPPORT study came out. This is the short-term androgen deprivation with pelvic lymph node or prostate bed only radiotherapy. And it was actually a 3-arm study. Okay, so it took patients with a PSA of 0.1 to 1, and it randomized them to prostate bed only. This is salvage, right? So prostate bed only, prostate bed and hormones, or pelvis and prostate bed and hormones. Okay, those were the 3 arms. Prior to this study, we rarely did pelvic radiation for unless they had a very high risk of lymph node metastatic disease, and we rarely did hormone therapy because there was no evidence that it helped, and there was a lot of evidence that it impacted the quality of life. They found a significant difference in the arms. Basically, the more you throw the kitchen sink way of treating the hormone therapy and the pelvic radiation and the prostate bed had better PSA control than each successive level of less treatment. Obviously, there's more GI events. The more you radiate, the more likely you are to have toxicity. And there was higher long-term suppression because now instead of treating a small band, you're treating a larger area, including much of the pelvis in your radiotherapy. Oh, no, I don't think they did a nodal subset analysis. This has, I think so far has only been reported at the meeting, so the manuscript hasn't come out yet. So
I was curious to see it. I don't think that it's come out because I was also, is there a difference between arms? There's an overall difference, right? How much of it is mediated by ADT?
Right. 6 months. 6 months. 6 months. Right. So you're right. I mean, it looks like most of this is from the ADT, right? So if your PSA is over 0.34, sorry, if your PSA is less than 0.34, there's no difference in the arms that did pelvis or not, as long as you got ADT, so less than 0.34. So what I think the answer from this is a little complicated, and so this is what I took away from it, and we'll see whether the manuscript sheds more light on, amount of pelvic nodal dissection, et cetera. But if the PSA is less than 0.1, so they wouldn't have been included in the study. I think those are patients you can still just do prostate bed radiotherapy alone, right? You don't need to put them down the hormone therapy path and radiate their entire pelvis. If it's between 0.1 and 0.34, that's when hormone therapy helps. And then above 0.34, I think you really need to now start doing pelvic radiation. We do pelvic IMRT here, so it's not this large four-field treatment. So typically those side effects are mainly short-term. And then above 1, you start to think, okay, we need to intensify therapy even more. And so there are a lot of studies that are in this space. Formula 509, which actually we have, we either have open or are going to open here soon, which is Paul Nguyen's study looking at ENZA. We have GU006, which is not open here but accruing nationally. And then we have this RTOG Foundation study, which just opened a month ago. This is Paul's study, salvage RT and hormone therapy with or without abiraterone and enzalutamide. Yeah, so once they failed, they could have salvage hormone therapy afterwards. So that will impact like survival, for example, for sure. Right.
What could be the case is that the ADT is driving the similarity between the curves, and the average time of developing ADT resistance is 24 months. And maybe as you followed out, the radiation that actually killed the prostate cancer cells and thus longer freedom from progression might start to go up. ADT without resistance might go down. There might be a longer term closer to getting that resistance?
Yeah, for sure. You know, and the fact that the Shipley study reported 13 years or 15 years, that, you know, the 2 years of Casodex versus none salvage study reported a survival benefit only like 13 or 14 years after that trial was mounted, points to that for sure. It'll be interesting to see what happens 10, 12 years down the line, for sure. So again, these are studies that are looking at intensification of therapy beyond the 6 months of hormone therapy. RTOG Foundation study is going to look at 2 years of GnRH analog with or without 2 years of enzalutamide. This is long therapy in the salvage setting and much longer than we typically have done. So I don't know how many. We'll talk, but I don't know what the enthusiasm will be for this type of salvage therapy. The second key trial that I was very interested in was this Astro plenary session, asking if African American men are at higher risk or lower risk of benefit from radiotherapy. We know they're at higher risk of dying of prostate cancer, but there's been some data emerging that perhaps African American men are actually more sensitive to treatment. And so Dan, who's done like all of these studies, pulled together a whole bunch of studies from NRG and found that African American men had indicators of greater radiosensitivity genomically, had greater rates of double-stranded DNA repair pathway defects, and greater rates of immunologic pathway expression or pathways that seem to indicate a good immune response. And by the Porto score would have greater radiosensitivity. And he actually found that African American men actually had a lower prostate cancer specific mortality when treated compared to non-African American men. And so this is the opposite of what we thought was going to happen, right? So a lot of folks think African American men have more aggressive disease. They're dying more from prostate cancer. Turns out they actually respond better to treatment. And it mirrors work done in the metastatic castrate-resistant setting. And so it seems that the outcomes, the disparate outcomes for African American men versus non-African American men are from access to care, diagnosis, actually getting the care. And so obviously more work needs to be done in the disparities setting. But it appears that these men actually respond better to radiation than non-African American men. I thought that was a fascinating finding. And then finally, this is a study that's come up over and over again at Tumor Board, the Stampede study, the H cohort, looking at patients with newly diagnosed metastatic prostate cancer. And they randomized to prostate-directed or no radiotherapy. So not treating all the mets, just prostate-directed radiotherapy. They've gave kind of a weird fractionation schema. Basically, consider this as kind of a moderately intensive treatment. Okay, it's not quite what we do in the intact setting. It's not quite palliative radiation. It's kind of a moderately intensive treatment. All the patients had hormone therapy. They allowed docetaxel. And they stratified by high versus low metastatic risk. And I actually have quoted this wrong in Tumor Board. It's actually, the low risk is 3 or fewer bony metastases within the pelvis or axial skeleton and an unlimited number of pelvic lymph nodes. They didn't count pelvic lymph nodes in either of these. So that's the part I've gotten wrong in Tumor Board. As long as they didn't have visceral metastatic disease, they considered that a low burden. So this is a little controversial in terms of how we stratify, but in general, think of it as a couple mets, not too far in the bone, no distant metastatic disease. And so weirdly, I thought treating the prostate actually, even when you have metastatic disease, improves your failure-free survival. only in the low burden folks, right? If you have a high metastatic burden, prostate-directed radiotherapy is not beneficial. But if you have a low metastatic burden, prostate-directed radiotherapy is beneficial, even in terms of overall survival. I mean, I thought that was a weird, that was a very interesting outcome. So that leads very nicely into the last section, which is the treatment of oligometastatic prostate cancer. So this term oligometastatic, even though it was defined years ago in '95 by Hellman and Wexelbaum, it's really kind of only the last couple of years that we started to hear this word more and more, right? It's the idea that it's a clinically significant state. So this is a clinical definition to start. Obviously, it's a more complicated than just a clinical definition, but it's the intermediate state between localized and widely metastatic disease. It's the idea that if a patient has metastatic disease, oligometastatic disease, and you act locally, you can, should we use the cure word? I mean, you could improve their outcomes somehow, maybe cure them, but at least improve their outcomes with intensive local therapy. And I think that actually is very attractive and makes sense to us, right? Those of us who treat locally. And so we need to figure out what oligometastatic means for one thing. Is it synchronous oligometastatic? In other words, like the Stampede H cohort, is it the metastatic disease that's oligometastatic at the time of diagnosis? Or is it oligopersistent, meaning you treat this metastatic disease, but then there's one spot that remains? Or is it oligorecurrent, where you've treated, there's nothing left, and then this other spot pops up? These are all different clinical entities with different clinical meanings. And so we're working rapidly to try and differentiate these kind of types of oligometastatic disease. There's been a lot of studies in this space, one of them being this HORAD study, which looked at patients and randomized them with primary metastatic prostate cancer with primary bone disease, sorry, secondary bone disease, and randomized them to radiation and hormone therapy versus hormone therapy alone. And there's no difference in survival, but there was, and they treated the prostate alone, but there was a benefit in terms of PSA, progression-free survival. Okay, so this is a similar study, I think, to the Stampede H cohort. Similar. Popstar study did radiosurgery, this time not just to the prostate, but to also all the metastatic sites. Also found a progression-free survival. STOMP also found a progression-free survival. So again, multiple studies coming out, both randomized and non-randomized. This one I like a lot. I was an Orioles fan when I was a kid. So the Orioles study, Futran at Hopkins, looked at radiosurgery for all sites of metastatic disease. So this comes up in tumor board, right? Mr. So-and-so has 3 sites, only 3 sites metastatic disease. Should we go after them all with radiosurgery, a combination of surgery and radiation? Should we eliminate all gross disease? No survival benefit yet, only progression-free survival. Okay, so I feel like this is a relatively easy study to mount at a single institution, right? You have enough metastatic patients. You don't need that many patients. It seems kind of, hot and sexy to do radiosurgery to multiple metastatic sites. So I feel like that's one of the reasons why there's so many studies going on. But hopefully at some point, this plus the cooperative group studies will have better ideas of how to treat, what doses to use, what do we worry about in terms of toxicity, and in a couple years we'll know. These are slides from a breast cancer study where we're starting to learn the actual techniques and limitations of radiosurgery to metastatic sites, and hopefully in a couple years this will become standardized, right? standardized. So that radiosurgery at institution A means the same thing as institution B. So what I take away from this, I use a combination of the Oriel technique and the BR002 technique. I adhere to this AAPM TG101, which is this American Academy of Physicists in Medicine limitations for different parts of the body in terms of radiosurgery, and everyone gets a CT scan guidance at least. And Stomp did similar, Popstar. Again, more and more we're starting to standardize therapy. People are looking at pelvic radiation as well for metastatic disease. Again, this is just illustrating, we're trying to figure out, do we just treat the spot? Do we treat regionally? Do we treat, how far do we go in terms of radiosurgery for these treatments? But I think for now, we can say that in de novo metastatic disease with low tumor burden, prostate-directed radiotherapy does have a survival benefit. I think I'm okay saying that. And those patients we have been treating after tumor board discussion. For oligorecurrent disease or oligopersistent disease, all I can promise a patient is that I'm going to make their PSA be controlled for a little bit longer. Right? So this is a very different recommendation than if they present with oligometastatic disease. So this happens as well in tumor board. Oh, so-and-so had a treatment, they had hormone therapy, and then they had chemo, and they just have one spot left. Can you treat that spot? The answer is yes, we can. All I can promise is that there's a better chance that their PSA is going to be under control. But I'm not going to promise any sort of survival benefit. And some folks still go for it. Okay? But in the meantime, we are going to have a joint Astro-RSNA conference in DC, trying to discuss oligometastatic disease. There's going to be folks discussing imaging, novel PET tracers, immune, like T-cell linked PET tracers. We'll have folks talking about radiomics, artificial intelligence, people talking about the immunobiology of oligometastatic disease. So I think it's going to be a fascinating conference. So if you're free on June 13th and 14th and want to hear people talk about radiosurgery and interventional radiology in the treatment of oligometastatic disease, please come down to DC. What about prostatectomy, right? So this is a study, SWOG 1802, I think, is like in design or accruing?
Design is accruing around the country. It opened in September or November officially. We should be open here imminently. We're sort of just getting the final paperwork through. But anyone who has oligometastatic disease needs to be on 6 months of hormones before randomization anyway. So we can still recruit those patients later.
So this is a very exciting study. And so we'll see whether, the ultimate local therapy, removing the prostate improves outcomes. So that's a very interesting study. Yeah.
I wonder if it's going to be hard to approve this because here you have level 1 evidence. There's a survival benefit for patients with low metastatic burden. And I mean, that's been one hesitation of mine that currently exists. So you have that,
right?
A patient would have to decline that.
Right. So I think SWOG is considering adding a radiotherapy arm to 1802. Is that right? I think they're
there is. So I mean,
okay.
So the real hesitation is that there is evidence that radiation is of benefit, and people can get randomized to be just on lifelong hormones and get no radiation when we know that there's a benefit. So I think that's sort of, if they want to have surgery, then it's sort of surgery versus lifelong hormones. So that's a bigger question, but patients can also be on the radiotherapy arm. But it's sort of a little bit challenging to say, well, we know you can have radiation and we know that that works. We don't know if the surgery works, but if you want to have surgery, we can do that for you as part of the trial. But you're still going to be randomized to getting lifelong hormones versus hormones plus surgery. So you still may not get surgery if you want it. So I think there are some intellectual challenges to.
I wonder if, I mean, it's obviously too late to pivot to radiation surgery.
Right.
I mean, but
I mean, I don't know. I mean, I'm not part of that study group. I mean, yeah. I mean, who knows? Maybe I mean, I've seen weirder, right?
Well, it was going to be. It would have worked before sort of Stampede H, I think, was published. I don't know if they didn't know about that or.
Yeah.
I mean,
Yeah, I think this was in design or being designed before. So again, prostatectomy being looked at. This is the trombone study, testing radical prostatectomy in prostate cancer. That's actually my trombone. But thank you very much for inviting me. And I'll see you guys in 10 years, right? 9 years.
so James, we have a lot of patients that ask about Cyberknife. Can you just comment on that for all of our education?
So we had a yeah. Technology, sure.
So basically, what are the tools that you're using in the Cyberknife?
Right.
Is it just increasing the dose? I know you talked about
Right. Right.
the delivery method.
So Cyberknife is just a machine, right? Cyberknife is instead of a linear accelerator that rotates in one direction, it's a miniaturized linear accelerator on a robotic arm. So all Cyberknife adds is a 6th degree of freedom. At this point, with all modern radiotherapy machines, we have onboard imaging. We have the ability to image the patient every 10, every 5, every 30, whatever you decide, seconds, and detect fiducial markers in the prostate. So that kind of innovation that Cyberknife had years ago, I think is now incorporated in most modern radiotherapy machines. So when people say Cyberknife, I think they mean radiosurgery. They mean SBRT, or stereotactic body radiotherapy. That's what they mean. Right.
Do you have Cyberknife? I'm like, well,
So you can
have
say,
it, but we don't use it, but we do something that's similar, and then I send you to talk about the
you can
details.
say we had it. I mean, when we incorporated St. Raphael's, we briefly had a Cyberknife, and then we got rid of it because it wasn't as versatile as our other machines, and our other machines did the Cyberknife treatment just as well. So you can say, look, we had it. It's just they have great marketing, but it's the technique that's more important. And I do believe that our radiosurgery system is better than Cyberknife because we do real-time tracking, not every 30 seconds X-ray. Our treatment is shorter with our optimized linear accelerators. If the Cyberknife treatment on SBRT takes anywhere from half an hour to an hour, we do it in like 2 minutes of beam time. So I just think that our treatments are more homogeneous too. Cyberknife uses a miniaturized linear accelerator, and they're shooting from multiple angles. When you add up all those beams, you get more hot spots. Whereas with the current linear accelerators with VMAT, or volumetric modulated arc therapy, we get a more homogeneous dose to the prostate. So I think there's a lot of advantages to the way we deliver SBRT compared to Cyberknife. That said, I'm sure the Cyberknife people have their other, that push back on that and saying like, well, the heterogeneity is actually good. You get hotter inside the prostate, and that's actually good. But there's no difference, I think, is the bottom line between the way we do it and the way they do it. I think the way we do it is slightly more modern.
So your delivery method is by conventional, moderate hypofractionated, or SBRT.
Right. So the linear accelerator that I use for prostate radiation is the variant TrueBeam, and we can deliver either very fast fluence of radiation through the linear accelerator head that's optimized for radiosurgery, or we can deliver a standard fluence that's optimized for standard fractionation, or something in between.
So the most important thing is to have that device also adjuvant,
Right.
space or
Right.
these are the things that people really ask.
Right. The key is stereotaxis, right? So 3D localization in 3D space, and we do that with Calypso, and then a finely shaped beam, and we have these micro shaping basically on the linear accelerator head, micro MLCs, and fast output, and also 6 degrees of freedom in terms of positioning. Ours is in the couch. Our patient can go like this on the couch, and the treatment head rotates in that way. We're no skin pulling. I mean, weirdly, sometimes we do just to get them in the right position, and then we image them, and then the machine puts them in the right. There's still a little skin pulling.
Are people doing SBRT or Cyberknife without fiducials?
You should not. There are some, I'm sure there's someone in the country doing cone beam CT based SBRT where they just do a CT scan and they use that to localize the patient and they say, don't move, and then they treat, and then they get the patient off the table. I'm sure that's happening.
I've seen a few patients who've been treated like out of state.
Yeah.
They were not doing, which really surprised me.
It surprises me too. And so I would be very worried about that because the prostate definitely moves in between your cone beam and the end of treatment.
Yeah. I wonder if, yeah, it's interesting. You could see who, you know.
Yeah. But the spacer, the nice thing about spacer is now you can put a big margin on it. So there's some discussion quietly being had. Do we need IMRT anymore? Can we go back to 3D conformal therapy with spacer? Because now there's this big old pad between the prostate and the rectum. Do we need all of this fancy new technology that we've been incorporating all of these years? You know, I don't think anyone will ever do a regression study, a randomized study of going back in time and using those techniques. Because
yeah, the urologic literature has had some recent references to the risk of secondary malignancies from external beam radiation therapy, colon, bladder, et cetera, as opposed to brachytherapy. A significant risk. Some of that obviously is confounded by cigarette smoking, et cetera. What should we be telling our patients? What do you tell your patients?
So I tell patients that there is a second malignancy risk after external beam radiotherapy. I think that is completely true. The question is, what is the magnitude of that risk? And I don't know the answer to that because a lot of the studies that have looked at that are, you know, they use the SEER data, they go 20 years out, and it's all based on older therapies. The numbers I quote to patients are like, yeah, there's probably an additional risk of a colon cancer, probably 1 in 1,000, something like that. I don't know if that's too low. That's what I tell patients. You know,
there were some studies looking at 20-year follow-up that showed about, well, starting about 10 to 12 years after treatment, about a 1% year increase in age-adjusted relative risk.
Yeah, that's older techniques. It's also patients who've had prostate cancer and prostate cancer treatment and all the doctors associated with that. So, you know, I like Dan Petrolak did a study with SEER Medicare looking at bladder cancer risk or something after prostate radiation. Actually found the risk was lower or something like that. And that, of course, doesn't make sense, right? Radiation doesn't protect the bladder from bladder cancer, but it kind of shows the power of the epidemiology behind these second malignancy rates. So yes, radiation causes cancer. I think that's all we can say.
Second question, what's happened to brachytherapy?
Yeah, so brachytherapy, I came back in 2010. I was very enthusiastic about doing brachy. I went to Seattle for 2 weeks. I took the brachy course, came back. I think I was the only one who was enthusiastic about it. My mentor, Dr. Peschel, was not enthusiastic about it. And so it's mirrored declines nationally. Brachy has just gone down in favor of IMRT, in favor of radiosurgery, in favor of robotic prostatectomy. I think that patient group, the favorable risk patient with the low urinary good urinary function, right? Those patients are getting surgery or IMRT right now. Brachy's coming back, I think, because of the Ascend RT study that came out a couple years ago showing a benefit to brachytherapy boost in high-risk patients compared to external beam boost in high-risk patients. And so there's a lot of people around the country who think brachy, in addition to beam, is the standard for high-risk disease. Our response to that was to develop this radiosurgery boost protocol because the beam and brachy folks are the ones in my mind who have the most toxicity. They reported like a 15% grade 3 toxicity rate or something in the beam and brachy combo arm. So I'm very hesitant to do beam and brachy. I think if someone was very if one of you was very enthusiastic about it and we wanted to do a study on it, I'd be okay with it. but I think we can all agree that tough treatment.
That's a great talk. It's something we all need to know about, and it's really nicely put together. Thank you.
Yeah.
Near a certain 10 to 20 year prediction here, which is at our plenary sessions and our journals, there's always something about surgery versus radiation. And during all of those talks, it's always said, well, that's when they were doing formal theme. That's when they were doing brachy plus external. That's just brachy. Well, now it's IMRT. Well, that was 73 gray. Now it's 79. Now it's 81. And if your high dose, shorter fractionating, higher dose turns out to be the national standard, it's almost for certain 10 to 20 years from now, when our residents are senior attendings doing journal clubs, they'll be saying the same thing when it's surgery versus radiation. Well, we can't really say that because it's two different groups. It was a different era.
Yeah, I mean, I think that's why we can only rely on randomized studies for that comparison of surgery and radiation, right? You know, the only one I'm aware of is UK Protect, right, which didn't show a big difference. I think didn't show a big difference with observation either. Right? It showed differences in quality of life, for sure.
But if that radiation isn't used anymore, it becomes an irrelevant study.
Right. Yeah. No, I mean, or that surgery, right? So in the UK Protect, I think radiation came out a little bit more favorable, depending on who reads the study. But it came out a little more favorable than the surgery did, and then the argument is that it's older surgery. So I think you're right. That's the problem with prostate cancer is 10 years will go by and we're doing something different. Radiosurgical doses. People around the country are now doing 8 times 5. So you're right. Maybe I'll come back and say like, oh, 7.25 times 5, that's too low. No, we're doing 8. So, but we have to keep our residents and our academic residents employed with studies. You know, there's always going to be studies, comparative studies to do. Otherwise, you know, if we answer all the questions now, it's pretty boring.
Thank you very much.
Thank you.